Hey, it's Rob Potash with CSMI, and thank you for tuning in to episode number 7 of Isokinetics 101. The goal here is to introduce people to isokinetics and how to use them in the training room and in the clinic. We have two people. Our speakers are John Hisamoto down in Tampa, and then we've got Daniel, who's now in Atlanta. Johnny and Daniel, take it away.
All right. John, how's it going tonight?
Thanks, Rob. So it is going well, Daniel. How about yourself? Got a big house, got a big reno project going on, you got two girls sitting down there.
Absolutely. Getting everything going.
That's a beautiful thing.
Yeah, the move has.
So tell us what we're going to talk about tonight, Daniel.
All right, so we are moving on from the training portion of the isokinetic dynamometer to the testing portion. So tonight we're going to go over isometric testing and how you can implement that into your return to play decisions. And then next month, John, you're going to teach us about isokinetic testing with a focus on the interrupted stroke eccentric function of the isokinetic test. So if anybody needs to catch up on any of the training things we talked about, the mobility, stability, strength, and control, you can go back to isokinetics101.org and watch those on demand. But you can follow along in the next few months to get into the testing side of it.
All right. Sounds good. And let me just kind of put out while you get this started, big shout out again to all of our international listeners. We appreciate that you guys are part of our audience tonight. And any questions that you guys have, please send them in. We're interested in answering any of those questions. And one of the things that we're talking about doing, and I want to just kind of put it out there for you to see how interested you are, is when we complete this by December, is to have a users meeting, next January, February, where you can be invited in. And we actually do a 2.5 day program on everything that we've kind of talked about with a huge hands-on approach. So if you're interested in that, make sure that you let Rob Potash know at CMSI.
All right.
Thanks, Daniel.
Fantastic, John. I'm going to go ahead and knock out my webcam and we can get started. All right. So like he was saying, get a hold of Rob. You can see on this this slide here, I have Rob's email, not only about the users meeting or any CEUs that you're interested in getting for this, but also for liking us on Facebook, whether it's CSMI's page or my personal page. So you can contact us all right there. All right, speaking of CSMI, let's check out their cybextest.org. You can register your clinic for free. Patients and physicians, they use this as a database to find clinics who are able to perform isokinetic testing. And this is a great way for them to find you. Also, if you've missed previous episodes, go back and review, or you can, if you just forgot something that we said, you can go back and catch up on with that. So back in episode 5, when we talked about isokinetic strengthening, if you couldn't tell, John can talk isokinetics, especially eccentrics, all day long. But unfortunately, we are limited by time in this program, so we didn't get to some of the additional videos. So if you go to my YouTube page right there, and there's the address if you need to pause this and write it down, you can go to that, and I have videos on how to set up shoulder, elbow, wrist, forearm, and ankle for isokinetic strengthening. Also with episode 6, I left a video off, and that was just how to set up the isotonic mode of exercise in the dashboard. So I uploaded those there for you. Check them out. Also check out PT Inquest podcast. It's a great online journal club, and it's also fun to listen to, as well as bensound.com. Thank you for the introduction music. So if you look back at our program's roadmap, we start out with an introduction to history and science in episode 1, and then we did a program preview in episode 2 where we showed all the training and testing modules. Then we went through episodes 3 through 6 where we went over mobility, stability, strength, and control. But now we've moved on to the testing portion of the program. Again, today I'm going to go over isometric testing, and next month John is going to go over the isokinetic test. After that, we're going to go into how you can put it all together. as far as the plan of care for your athlete. I'll do one on lower extremity, and then the next month after that, John will do one on upper extremity. And we're going to talk about different pathologies of when to include mobility, stability, strength, control, and testing, but also how you can include it within a treatment session, how it all comes together. So that's what we're going to go to next after we finish the testing portion. All right, so again today and in the next month, we're going to talk about isometric and isokinetic testing, and that's going to complete our continuum of care loop. So this is a poster that CSMI came up with a few years ago. And this sets up the presentation perfectly. The big question is, where do you want to test your athlete? Do you want the first time that they're going to maximally test their strength to be on the field while they're getting tackled or making a cut? Or do you want it to test in that training room? And we're going to show you how to include dynamometer testing along with the functional testing, so that you're not guessing, if your athlete's ready to go back to the field or not. Now, the next big question is your athlete prepared? Have they been a good student and prepared over the course of their rehab, or did they pull an all-nighter the last few weeks to try to get ready for the season? If this is your athlete, you should know where they are, either because you've included testing throughout the plan of care, as you'll see today, or because you've used the various training modules that we've described, and so you kind of know the torque amounts that they can produce and what their deficiencies are. But let's play a scenario, and John and I see this all the time. An athlete sent over to you by their doctor for testing. Now, this isn't your athlete. You've never seen them before. They worked really hard in their first 3 to 4 months of rehab at another facility. But when they were released to that independent gym program, unfortunately, they didn't hit the weights or do their sports training as they were supposed to. Now, their doctor has no idea if they're ready. And hopefully they send them over to you for that the assessment. And hopefully the start of the season isn't the next week. There's nothing worse than an athlete who's convinced that they're ready to go back to play, and then you do the test and the objective data tells you that realistically they're 1 to 2 months away from achieving just the minimal strength parameters. And then you have to break the news to them that they're not where they need to be. So we see it all the time. So I like this poster here because if they know they're going to fail, they're not going to freak out about it. But when you tell that athlete, hey, you're not here, and you're not where they need to be, and you present them with that objective data, that kind of lights a fire under them and gets them to be motivated again. All right, let's move on to some research. I have some studies we're going to present today. Our first was performed by Christiani et al., and they looked at readiness for return to play at 6 months post-op. Now, this was a 15-year study, and it included over 4,000 ACL reconstruction patients. They assessed patients with an isokinetic quadricep and hamstring, as well as the functional side, the single leg triple hop test, and they scored them based on a percentage of the other limb. Now, we know this as the limb symmetry index, or LSI. If you hear me say LSI or see it in the presentation, that's what I'm talking about on here. So if these athletes in this study, if they scored 90% better of limb symmetry on all 3 measures, they were considered to be symmetric overall. And the findings for this is that only 1 in 5, or 20%, only 20% were symmetric in all 3 of these measures. Now, note here that 68% were symmetric in their hop testing. All right, this is at 6 months. So 68% were symmetric in their hop testing, but only 36% were symmetric in their quad and 47% in their hamstring strength. So this study shows us a few things. One, subjects do better on functional tests at this point than they do on isolated muscle tests. The function of hopping, that improves faster than muscle strength. And we're going to see in a few minutes how patients compensate functionally. We have evidence of how they make compensations in order to hop. And those compensations aren't going to set them up for success. Now, I have a buddy that works the NFL Combine with me every year, Jeff Keith. He's out of Huntsville, Alabama. Now, he went to a George Davies lecture, And now I'm paraphrasing this because I wasn't there, but he told me that, Davies mentioned how you can't truly have functional control of movement with a dysfunctional segment. And that's exactly what I'm talking about here. So your patients can compensate for those weaknesses. They can cover it up during those functional tests. All right, a second thing to note is any meniscal involvement, that reduced their likelihood of symmetry. And they actually found that hamstring grafts did better than the patellar tendon grafts. Now, a few other things to note here is that the isokinetic test they performed, that's the standard isokinetic test that only looks at the concentric motions. Now, next month, you're going to hear about, John's going to tell you about the interrupted stroke test that also looks at the eccentric function, and it gives us a much better look at readiness. Now, last thing to take away here, and again, this just hits me like a ton of bricks. Only 1 in 5 meet minimal return to play standards at 6 months. Now, when I graduated from my athletic training program, I remember the plan of care return to play. It was like 9 to 12 months at that time, but then we started to see it creep slowly towards being sooner or earlier and earlier, to where it was 7 to 9 months, and now it's 6 months across the board. I even had a physician released my athlete at 5 months out after the ACL, and I had objective tests that say he's not ready to go. Well, that athlete hears that he's ready to go, so of course he goes back to playing soccer, and 3 months later he's walking back in the clinic with a meniscus repair. And so we're finding out, not just with this study, but with other studies, that the longer you wait, the closer to that 9-month mark, the lower the risk of re-injury is. So there's countless studies that we could talk about with those that they're out there. Okay, our next study. This was performed by Barfoot et al. They compared concentric isokinetic quad strength and single leg hop testing for ACLs. And they looked at this at 6 months and 12 months post-op. Now at 6 months, again, 68% of the patients had a symmetric hop test, but here only 28% had some symmetry in the quad. Now 12 months, a year after surgery, now it was 90% had a symmetric hop test, and 46 had a symmetric quad. So even at 1 year, only 46% are showing that quad symmetry. So again, a third of patients have a symmetric quad at 6 months and half at 12 months. Again, this is showing us that the recovery of hopping distance happens sooner than strength. So these studies, along with the next ones, they're showing you why we can't just do the functional hop testing, why you need to include the dynamometer testing as well. So again, they found that quad strength is associated with hopping distance. If you have improved quad symmetry and quad strength, you're going to do better hopping. But just because somebody was symmetric hopping, that did not correlate with quad strength. So one can prove, quad strength, shows ties in with hopping, but hopping doesn't tie in with quad strength. And that just kind of reminded me of this meme. I'm a big fan of my memes, so I had to throw one of them in there. All right, so I got a group here that did my next 5 studies, and we'll kind of go through these quickly. This was interesting how they did this. So, and again, this next group of studies were performed by the same group of researchers. Now, in the first 3 studies, they compared patients who underwent ACL reconstruction, and this was at the time of being cleared for return to sports. So everybody that was included in these, they were cleared for return to play. They tested the maximal voluntary isometric contraction, or MVIC, for both limbs. So they were using isometric testing. Those in the experimental ACL group were further divided into the high quad group of limb symmetry, and that's a 90% LSI or greater, or a low quad group of 85% LSI or less. Now, in this first study, they also assessed them with a IKDC for the subjective side, as well as the single leg hop test for the functional side. That way they had a comparison. All right, the results. Those in the ACL group as a whole were weaker, had worse function, and overall performed worse on the hop test compared to the controls. Well, that makes sense. But they broke it down to the high and the low quad group. The low quad group performed worse on the hop test compared to the high quad group and controls. But there was no difference between the hop test, and for those in the high quad group and the controls. So those who got that quad strength back, they did just as good in the hop test, the functional side, as the control group. Now, the ultimate finding here is that, again, quad strength predicts performance on hop test beyond graft type, presence of meniscus injury, knee pain, and knee symptoms. All right, the second study by this group, they used the same subdivision of their ACL groups, so the high quad and low quad strength. But this time they collected kinetic and kinematic data during a bilateral drop test using force plates. So they dropped off of a raised platform onto both legs at the same time. And they also used the 10 camera motion analysis. The low quad group demonstrated worse asymmetry in all kinetic and ground reaction variables compared to the high quad group and the control group. The low quad group, they landed with a straighter knee on the involved side. They had more ground reaction forces on the uninvolved versus the involved, and they loaded their uninvolved limb faster than the involved. So they loaded that involved limb slower. As with the previous study, again, quad strength estimated the limb symmetry during landing, and that's after controlling for the graft type, the meniscus injury, knee pain, and symptoms. All right, the third study, again, same subgrouping approach as before. This time they had them do a single leg drop test with 3D motion analysis. All of those in both the experimental groups demonstrated asymmetry during single leg drop tasks compared to controls. And the ACL reconstruction groups, again, you can predict compensations based on whether they were in the high quad or the low quad group. The low quad group compensated with increased trunk flexion, decreased knee flexion excursion, and decreased knee extension moments. So they're landing on a stiff knee. They're compensating through the trunk. So, you know, if you land on that stiff knee without allowing the hip to sink down and absorb some of that in the sagittal plane, you're just going to load that ACL even further and put yourself at a higher risk. All right, so this is the last ones from this group that I'm talking about. They did follow-ups 1 and 2 years later. And again, those who were in the in the low quad group at return to play, they did worse overall, functionally and symptomatically 1 and even 2 years later. Now, this is pretty amazing. Even 2 years later, those who were weaker at the time of their return to play have more issues. Now, we can guess as to why that is. I think that if an athlete's told they're ready to go back and play, and they really have these deficits that they're just not aware of because you don't do this testing, they're not going to continue to work toward building strength as aggressively. They think, in their mind, they're ready to go. But if we test them and we include this as part of that return to play decision making, and we do that at the time of return to play, and we tell them, or we find out and we identify them as not being ready, now they're going to work their strength more aggressively until they meet those standards. And once they meet those return to play standards, now not only are they going to be safer playing, but also we can see years later that they're going to do better. Our next study, this was done by Wilson et al., and they looked at the use of LSIs because the LSI, we'll find it's got some cracks in its foundation. So they looked at LSIs for making their return to sport decision. So they tested all their subjects in uninvolved quad and hop testing. Okay, they did this after their patients tore. So they tore their ACL, they let those symptoms kind of resolve, and then they tested the uninvolved isometric strength and their hop test. And then their subjects had their ACL reconstruction. And then 6 months later, they repeated the testing for both limbs. So they then analyzed the subject's quad strength and hop test using the same basic LSI, so how they compared at that 6-month post-op, but then they also used another measurement. They compared their involved limb at 6 months post-op with how the uninvolved limb was right after injury. And they called this the EPIC, EPIC, the estimated pre-injury capacity level. Not only did they compare it, but they also looked at injury rates for a minimum of 2 years. Their findings were pretty interesting here. So only 28% or 29% of patients met that 90% epic level for quad strength and hop tests. But 57% achieved 90% if you're looking at just that LSI, so that 6-month right or uninvolved versus involved. So also 34% of those that achieved that, that LSI 6-month post-op 90%, 34% didn't even achieve the 90% epic levels. So that's a lot of numbers and percentages to throw at you. Basically, the LSI at 6 months, so looking at my involved versus my uninvolved 6 months out, made them look like they were better than if you compared to prior to surgery of that non-injured leg. That makes sense. Not only is that uninvolved limb, it's not getting pushed for 6 months. You're going to have a lot of loss of strength in that limb at that point. So that makes sense there. When they looked at predicting injuries, the LSI was more sensitive, the epic level was more sensitive than the LSI in predicting that second injury. The LSI sensitivity was only 0.27, whereas the epic was 0.81. So it was a much higher sensitivity when you're looking at prediction of re-injury. So again, LSIs frequently overestimate the function after ACL. And again, John and I have known this for years. How good of a measure is it? How strong is that uninvolved limb after 6 months of not pushing its strength? But here's something to think about too. How strong was that uninvolved limb at time of tearing? Did your athlete tear their right side, but their left side was also weak and unbalanced, but they just so happened to tear that right side first? So if you're only using the uninvolved side as a comparison of readiness, you're missing the boat here. So John, he's been doing this for years, but this makes sense to me too, even when he was telling me about it, and that's using body weight. So a lot of the research out there shows that, we know that, peak torque concentric quad should be 100% body weight. John's also going to go over what the eccentric functions of these muscles should be, as well as ratios. But the nice thing about it is, especially with our American units, as much as I think our American units are bad, the American units line up perfectly on the machine. It's 1 foot-pound of torque for 1 pound of body weight. Whereas if you use the international units, it's a 3-to-1 ratio. At return to play, they should be able to produce 3 Newton meters of torque per 1 kilogram of body weight. And unfortunately, most of the research that compares strength at time of return to play to body weight, they're using that international Newton meter and kilograms. It just doesn't line up as good as the American units here. So that's one for America for that. So body weight is very important to use here. And again, we're going to go into that even more next month. All right, our next 2 studies, these are quick. They look at using rate of force production as a testing parameter as well. This is not just about how strong the quad or the hamstring is, but it's about how quickly it can produce that strength. In a functional activity, and even more so in sports, we're talking about fractions of a second that muscle is going to have to produce that load appropriately. And any delay in that contraction, that's going to contribute to that re-injury. So again, it's not just about how strong you are, but how quickly that muscle or that group of muscles can react to stabilize that knee and decelerate that motion. The first study here was done by Angelozzi et al. And again, I apologize for butchering some of these names. They assessed their group of male professional soccer players as part of their preseason screening. And they also, of those who tore their ACLs, they got tested again at 6 and 12 months post-op ACL reconstruction. Now, again, they were testing isometrically the MVIC, but they also assessed the rate of force development to 30, 50, and 90% of the MVICs. They found how quickly can they hit that 30, 50, and 90% of that maximal contraction. At the 6-month post-op mark, the average MVIC was 97% of the pre-injury. Now, this is much, much higher than what we saw earlier with the studies, where it was, 68%, or even I'm not going to look back at this, but I think it was like 28% or 30%. It was much lower who hit the quad strength at that 6-month mark, but here it was 97%. I think this is because everybody in this study was a professional soccer player, so they were already highly trained. They were in the training room every single day working on that strength, and they were working to get back as quickly as possible. But either way, their findings, when it came to that rate of force development, at the 30% mark, 80% of the athletes had achieved that. Now, when they looked at, how quickly they got that rate of force production or that power to half their contraction, it got down, just a little bit to 77%. But when they looked at, how quickly could they get that power back to 90%, that maximal contraction, only 63% had achieved that pre-injury level. And it was only at the 1-year mark that the average or the mean rate of force production value attained or exceeded the 90% pre-injury values. So again, despite the near recovery of strength at 6 months, they were still deficient in that rate of force production. So it's telling us that, functional, the hop test comes very quickly because you can compensate. And then strength, but even behind strength, the rate of force production of that power lags behind a little bit. This study here, what they did, this was done by Pua et al., and they wanted to evaluate the associations of quad strength and that rate of torque production. So they had 70 subjects with ACL reconstruction, and they did this at 6 weeks post-op. They tested their strength and their rate of force production. And then at 6 months later, they tested them functionally for single leg hop, for distance, single leg vertical jump test on a force plate that measured their jump height and ground reaction force and rate loading. They found that both strength and force production at 6 weeks were associated with hopping and jumping at 6 months. So you can predict how they're going to be based on where they are early on with testing. Now, the single leg hop distance was more closely associated with the maximal strength, and the vertical jump height and the ground reaction measures, ground reaction force measures, that was more associated with that rate of force production. So both the quad measures were associated with the loading rate. So basically, the quad strength and the rate of force production, they're complementary, but they're different. They have distinct predictors of future hopping. And again, you should include this as part of that return to play testing as well, because it gives you all those measures all in one test with the HUMAC software. That's very nice. All right, this last one here. What they did, this was a great study done by Harput et al. In 2015. And what they did is they looked at an isometric dynamometer test in the early phases of rehab. So they had all their subjects here were hamstring autografts. They tested them, their quad and the hamstring, at weeks 4, 8, and 12. And they found that both the uninvolved and the involved improved strength over time, as well as the indices, the LSIs for both muscle groups improved. And the biggest thing is that they showed it's safe to test in the early phases of rehab. And you can use this as a way to monitor your athletes early on. That way you can tell if they've, is one muscle group improving faster than the other? Is your athlete falling into a plateau? I tested them at week 8, and then I retest them at week 12. The hamstring is getting stronger, but that quad isn't. But their function is improving. They're progressing through their rehab. That's because they're using their posterior chain. That might be telling you, you could dig into it as why, maybe they're pushing too hard functionally, and they're getting knee irritation, and that knee irritation or swelling is shutting down that quadricep. So they're not going to be able to increase their force of the quadricep, and that can be making them have to use that posterior chain. When you find this early on, it's much easier to correct than it is later on when you're talking about full out isokinetic testing at 5, 6, and 7 months. So you can use isometric testing throughout the entire program. And I talked everything on ACLs today. It's not just about the ACLs. You can do this with all of your rotator cuffs, your Bankart, your Tommy John repairs. If you want to look at their shoulder strength, you can use these tests when it's appropriate in their plan of care to track their progress. All right, back to ACLs. Now I typically hold off on the isometric test until week 8. Yes, you could test them at week 4. It's going to tell you that their muscles are crap, obviously. I don't even do it then, because that's right when I'm just beginning doing multi-angle isometrics at that very light load. So there's no point, in my opinion, to load them at that 4-week mark to see what their strength is. So I start the first isometric test at week 8, and then I repeat it at week 12, sometimes at week 16. At week 16, I actually like to perform the standard isokinetic test. By standard, I mean the 2-speed, 60 and 300 degree per second, concentric quad, concentric hamstring. Now, John is not a fan of this test, and I'll tell him, or I'll let him tell you about that next month. There's times where this test does come in handy. I like to use it at week 16 just to get it, more dynamic. Like John told us in episode 5, you can produce less force concentrically than you can isometrically. So you're going to get less torque produced, but having that knee moving while they're producing the force, I think it brings a little more dynamic into it. But I only use it then. At week 20, that's when I like to go to that interrupted stroke test that John's going to tell you about. We don't use it before that 5-month mark, just because when you're loading maximally eccentrically that hard, that's a lot of force that can be produced. So we hold off on that until they've had, they went beyond that weakest stage of the ACL, the 10 to 12 week point where everything is weak, and then they've had about a month or 2 beyond that for the graft to get more solidified in there and for them to get stronger. So we hold off on that until week 20. Now at that point on, you test them every 4 weeks or every month. So you test them at 5 months, 6 months, until they meet that return to play criteria. And again, it's not just the isokinetic test. You got to include the function test. I like to do the 30-second step down test at week 12, or a sit to stand test at week 8. I don't like to do the triple hop testing until weeks 20, when they've been doing plyometrics for a month. So you got to include the function side of it. Absolutely. You got to include the subjective scales, whether that's the lower extremity function scale or another one, but you got to include all of that as well. And that is what you base your return to play on. Now, here's the kicker, and this is important here, is that when you have an athlete who is in the off season, right? You work their ACL, whether it was this last year or they've tore 3 years ago. When they're in the off season, you need them to come in and test. That is extremely important. That way, you know that they're ready to go for that upcoming season. Ideally, it's not right before the season. Hopefully, they come in, they have about a month or 6 weeks before the season starts again. That way they can see where they are at that point, and hopefully they come in and they test out perfect and they're ready to go. But if they are a little deficient, you can identify those right there, and they still have another month to a month and a half in order to make up those deficiencies and before the start of the season. John's pitchers that he's had over the years, they all do this as well, not just for ACLs. They come in because they need to know that their rotator cuff is ready to go for that next season. So that's big. Get your athletes in, even if it was 2, 4, 5 years ago. Routine testing to make sure that they're ready to go is really important. All right, this isn't just about your ACLs, okay? Any of your general orthopedic patients this is your go-to test. This test is really quick. I mean, I'm gonna show you the entire testing procedure I'm just gonna show you the quad, but it's a really fast test. So your general ortho patients, think about it. We use manual muscle testing on all of our patients. And that's exactly what this is. It's just a manual muscle test, but it's giving us that level of precision measurement, and it takes away the subjective element from the assessor. We test all of our post-op patients as soon as it's appropriate to test them. And again, we'll cover that in those plan of cares, episodes 9 and 10. Let's see, we also test our fall prevention patients, our balance disorder patients, because we know that quad strength is a major contributor to falls. And this gives us a way to assess them. We test our neuro patients, including after strokes and patients with CP. John's seen countless athletes with CP in his career, and he can talk all day about dynamometer training and testing and how it's a great approach for them as well. Now, you're not looking at the same parameters for your general population, your TKAs, your fall prevention. You're not looking for them to get 100% body weight peak torque. All right, then you are really using that LSI or that other limb. Also, it's a good baseline and progression measurement. So you don't have to be as particular with what metrics they're meeting before they can be discharged from that. All right, your test procedure, always perform a warm-up. We like to go on the bike, the treadmill, the total gym. I like to use air squats and walking lunges with stretching, some RDLs. During the warm-up, put their patient information into the computer, explain to them the testing procedure as well. All right, so here's the thing about that. Let's say it's early in the process, 12 weeks out of an ACL. Tell them what to expect. They are not going to meet return to play parameters at 12 weeks out. That way, this athlete's not going into it with unrealistic expectations. Test the uninvolved limb first. Take your time setting them up. All right, so you test the uninvolved limb first. I like to do for ACLs, I test the quad of the uninvolved and I go right into the hamstring all in one protocol. And then they stay on the machine and all you have to do is rotate and set up the other side. Again, take your time with that alignment. After the test is finished, have your patient do a little cool down, 10, 15 minutes at most. That gives you time to interpret the data, to go over the graphs, go over the numbers. I like to do calculations and kind of get my thoughts together before I present with them. Go over the test with the patient. Take the time to explain to them. And remember, it's not always just the patient that's standing there looking at you. Lots of times their athletic trainer or their coach is there with them. Their parents are sometimes, staring at you, wanting to know, your interpretation, not just numbers, but what the numbers mean. So take time to go over that with your patients after the test. All right, let's go on to some videos. So bear with me for just a moment while I get my video loaded up. I just have a couple short videos to show today. Okay, so from your main screen, you got to select your patient first. So here I'm selecting my patient, then you click on test. From test, what you have to do is go down to the joint in the action, so knee extension, sitting. Now you're going to check select your protocol. Now, if you don't have this protocol in your machine, it's very easy to do. In a previous, I think it was the isometric stability, I went over how to write a protocol. This is your exercise screen. Make sure that box gravity torque data is selected. Go to your uninvolved limb first and click all sets. Now this is where you're going to set up your patient, right? Just like we've done for all of our exercise in the past, okay? If you want to, in this box where I'm going to right now, you can even put in the adapter length. That way you can precisely have it at the exact same length as what you had or that you'll test before or that you'll test later. Again, I usually leave that blank, but you can put it in. All right, so you're gonna set up your anatomic zero and range of motion like you've seen in so many other videos before. Now for isometric testing, we're gonna test them at 60 degrees. Let me pause here. We're gonna test our athlete at 60 degrees of knee flexion for both the quad and the hamstring. Now, if you're testing a shoulder, ER and IR, we're gonna do that in the scapular plane that we've described in previous videos. But we're going to do it at 0 degrees of rotation, so a neutral rotation. When you're setting up with this software through the HUMAC software, the range of motion has to have 10 degrees on either side of that angle in order for you to start and run the test. I will go ahead and just set the range of motion from 10 to 80 because that's what John and I test our isokinetics at. So if you put it in here now under this patient, it's going to be saved in later on. So just to skip a step later on when I do their isokinetic test, I just go ahead and put them from 10 to 80 here. So again, I set my extension, set my flexion. Once you have that there, it's going to give you your mechanical stops, set anatomic 0, and click OK. Now, when you click OK, since we selected the gravity correction option, we need to weigh that limb in the adapter arm. That's usually like 10 to 20 pounds worth of torque. So you lift that leg up, and you can select any angle because the software computes that, but you lock that in, and then once they relax, you click the weigh button. So here I click weigh limb. The software is going to compute all that in. Now, when you click unlock, that limb's going to fall. There's your data there. But when you click the unlock button, if you're not holding that limb, it's going to go into free fall. So make sure you're holding onto the adapter like that. Then you can click unlock and lower it down. Now the machine's automatically going to move the patient to the testing angle because that was something that we selected in the testing protocol. Again, you can go back to episode 4 on how to write a protocol. All right, so here's our warm up. All right, we have 7 reps built in. We have 2 reps each at 25% effort, 2 at 50% effort, and 2 at 75%. And then the last rep is 100% effort. Again, these are warm ups. It doesn't collect these. Each rep is held for 5 seconds with a 10-second rest in between. This allows them to warm up the muscle further, as well as familiarize themselves with the machine and the protocol. After each rep, I ask them how they're doing. Let me pause this here because this is important. I want to make sure that we cover this. All right, after each rep, I ask them how they're feeling with that rep. If they have no pain, great. 25% no pain, let's move on to 50%. 50% no pain, move on to 75. 75 no pain, move on to 100. Fantastic. You're testing them at 100% of their effort. But let's say they feel it a little. Let's say this, 25 was good. They get to 50% and they say, oh, I feel it a little. This doesn't hurt, but I like to say under 4 out of 10. If it's right there, that's okay. I'm all right with that. If it's above that 3 to 4 out of 10 threshold, they need to hold it back a little bit. So let's say 50% felt fine, they get to 75%. That doesn't feel good. It's above 4 out of 10. I tell them for your test, you're gonna stay below that pain threshold. All right. So after each of those warm-up reps, you're assessing how they're doing it. Don't just ask them. Watch their face. All right. So let's go ahead and we're gonna finish watching the warm-up. So for this, we have torque along the y-axis and time, that 5 seconds, along the x-axis. When the screen comes back up, you'll see, you can look in the top left corner. It'll give you the max torque for the muscle of the set so far. It gives you the reps across the right in the center at the top of the screen as well. Another thing to keep in mind, you control this test. Before each rep, you need to make sure that that rest clock completely clears out all the way to 0. And then you give them the command of on your mark, get set, go, or something similar. If they're preloading that adapter arm in the dynamometer, then it's going to mess up your rate of force production values when it comes to the test or the results. So they don't push until you say go. So again, watch the clock. After it goes away, I'll say on your mark, get set, go. Then she pushes. The screen scales as they go. So if it's at 20 foot-pounds on the screen and they go above that, it's going to scale up to that. All right, so I'm going to fast forward through the 1 minute rest. All right, the warm-up reps are completed. Now we have the test. Now the test, it's the exact same thing, but it's just 3 reps at maximal effort or below that pain threshold. It's a 5-second contraction with a 10-second rest in between. Now they should be showing you signs of exertion. They should be making faces, turning red, grunting. If they're just smiling at you or making no expression, you need to give them, you need to motivate them. if you go to the combine, you can hear some of our therapists screaming from down the hall with how much motivation we're giving. The key there, though, is if you're going to motivate them for one limb and get loud and get it going, you need to do it for the other limb as well. So you can't just cheer them on for their involved and not do it for the uninvolved as well. Now, on this video, that was it. I just showed you the quad, just to keep it short. But I usually have my protocols go from the quad right into the hamstring. So from that, we would do our 7 warm-up reps for the hamstring, then the test for the hamstring, and then we keep them in the chair. We turn everything around, line them up, and do the other. It's a very fast test. It doesn't take that much time at all. All right, so what I'm going to do is load up the data interpretation video, and then we'll go into some questions. All right, so after the test, this is your report screen. Now, I've done multiple sets of exercises and tested with this athlete, so there's a lot of reports on there, but it would be the top one. Just click the preview button and that'll get it going. All right, at the top of the screen here, this is the patient information. Now, I blocked this out. That way you can't get, for HIPAA, it's for privacy, okay? So I blocked that out. Let me play and unmute myself again. This next line here contains, right here, that's testing parameters. And this shows that it's an isometric test of her quadriceps. Again, I didn't include the hamstring in this report, but I haven't, let me pause again. I have an example of that in the handout that you were provided. All right, in this graph, we can see the same plot of torque versus time, but what it did is that average the 3 reps for the numbers, but it's giving us the best rep for each. Now you can put each rep in this. You can have it do the maximal, the minimal, and the average as well. I just had it put the best one in. But we can see here that the right is, the right limb is in blue and the left limb is in red. And we can see there's a pretty significant difference in her 2 limbs here. Okay, this first set of data here, all right, this is the peak torque values. And her right quad, it achieved 65 foot-pounds of torque, but her left was only 15 foot-pounds of torque. So that's a 77% difference. The next line over is the coefficient of variance. And this is a measure of how closely those 3 reps match each other. Her right quad is very close at 0.04, but her left was bad at 0.56 variance. Now this was due to poor muscle control and not lack of effort. Now, the third line over shows you what the torque compares to body weight. And John, he's going to discuss, isokinetic testing, that peak torque quad should be 100% body weight. If you remember back to episode 5, the force velocity curve, remember, isometrically, you can produce more torque than you can concentrically. So 100% body weight is a good measurement to use to compare here. And again, if you're testing the hamstrings, you're looking at that traditional 60 to 80% ratio. And again, this is where the American units of pounds to foot-pounds comes in handy, because it's 1 foot-pound of torque to 1 pound of body weight. Look at her values. Her right leg, her good leg, a non-surgery leg, it only got 48% of her body weight, and that's her good leg. Her uninvolved limb hit 11% of its body weight. Now again, my patient here is only 8 weeks out, so I don't expect it to be good, but you can see just there how quickly her uninvolved limb weakened up. And she's a professional dancer. She runs a dance studio. So she's strong, she's very fit. Now again, she had a lot of quad activation issues and active extension issues, not only after surgery, but before surgery, after her injury. So it was a good measurement. It was a great baseline to show us just how weak she was at this point. So let me pause or play, and then I will unmute myself. All right, once my box moves down to the next set of data points, it's the same setup. It tells you right versus left, coefficient of variance, as well as the difference compared bilaterally. The next set of data down, however, it's looking at the average torque over the 5 seconds, whereas that top one, where my box is right now, that's the peak torque. I'm just waiting for that to drop down. Below that, once it does, you'll see parts where it says peak torque slope at the bottom of, or the middle of the screen of the data. That's your rate of force production. Again, I'm just waiting for the box and the video to catch up. All right, here we go. This is our rate of force production. It gives you overall power, just the peak torque slope in foot-pounds per seconds, right versus left, and their coefficient of variance. The body weight percent doesn't matter as much with this. Below that, we have time to half torque, or half peak. And that's a good measurement to give you that, that quick, just like the one study where it did the 50% MBIC. Now I'm gonna not show you these next ones, but there are ways in the software. It's very easy to show progression, a progress test. Let me pause there. All right, if you look at the top of the screen, you have report, you have progress. You can also go to the drop down above those icons to under report, and it gives you even what's called the involved retest. And that's where you can compare the EPIC or EPIC of one limb now versus one limb later. So that's all in the software. It's all the same general setup. It's very easy to use and very user friendly. And those are the things that we can go over more next time if we have time for it. But I wanted to invite John back on. Let me go ahead and pull up our screen here. All right, John, I hear that you're back on with us.
I am, Daniel.
All right, let's pull our webcams back up because I did get a couple questions, not specifically today, but I've gotten these before. And I mentioned this a little bit is when we're looking, I had a question about ratios. All right, everybody uses that 60 to 80%, or I just say 70% concentric. But if we're doing an eccentric test, right, like what you're going to talk about next month, are we looking at the same ratios?
So to make sure that everybody understands what we're really going to be talking about, restate that question one more time for me so that
when we're doing, I got a question about when we're doing, or
so
when
are we talking concentric to eccentric ratios?
Exactly.
Or yeah,
okay.
yeah,
So typically everybody thinks you have to, if you're only doing concentric testing, right, you want that hamstring to be 60 to 80% of the quad strength.
Correct.
Can you give a little preview onto how, just one way, as far as ratios, how it's going to be a little different when we look at that next month? And you were right on.
It is going to be.
You were right on what I was thinking of as far as looking at the concentric of one muscle group versus the eccentric of another.
And that's what becomes important, because a lot of times we already know, if we just look at a quadricep, for instance, that eccentrically we should be stronger throughout the entire range of motion than we are concentrically, and we should be stronger by 10 to 30%. So we know that we're going to be stronger all the way through, so we can measure that both concentrically and eccentrically on the quadricep and hamstring. But let's look at those soccer players in particular, the ones that really have a lot of hamstring injuries or strains that are occurring now. Is there a better way for us to kind of measure their force production, especially of the hamstrings? Because one of the things that we know is that if we're training them to load really effectively on the quadricep standpoint, they're going to start to accelerate even faster. And that's part of the stretch shortening cycle. So as our eccentric contraction becomes more effective, we're able to actually generate more force concentrically. So if our quadricep increases force concentrically in that speed aspect, what does the hamstrings have to do?
Eccentrically
They
load.
have to decelerate at a faster rate eccentrically, right? So where do the most injuries occur? They happen when the quad is contracting concentrically and the hamstring has to lengthen very quickly eccentrically. So
that's very
one of the
similar
better
to the
ways for
rotator
us,
cuff as well.
exactly. One of the better ways for us to really pay attention to this is what is the quadriceps concentric measurement to the hamstring's eccentric component to see whether or not their quad ham relationship is a little bit more appropriate.
And they've been calling that the functional ratio.
And we've been
that's
doing
one
that for about
question
25 years, yeah.
that was one question that came through over the last few webinars. Another one I already covered is when you're testing, the total knee or other surgical or non-surgical, what are you using as your baseline? Here I was telling all about how the LSI was a bad measurement and you had to go by body weight or power. What do you look for?
So if we're really talking about, and again, the great part about these questions is they weren't asked ahead of time. You're presenting it to me right now. So it depends on the patient. So we're going to look at that patient's overall function, their height, their weight, their ability to perform. I like the fact that you talked about our balanced patients because that's one of the areas that we really need to pay attention to. So I want to look at, are they actually functioning and producing the correct torque ratios through the range of motion so that they're aligning both concentric and eccentric measurements and they don't have a deficit in the eccentric motor contraction because that's one of the points that we really see, and it's actually been measured. You can go back to 1986, Bill Stauber, Greg Bennett, Medicine, Science, Sports, and Exercise was the very first time anyone talked about isokinetic exercise really looking at an eccentric deficit. And we see it all the time now that we're testing that way. But they really looked at, you could actually have an eccentric deficit when you don't have a concentric deficit. And so we may see that with our post-surgical patients, with anyone that has an injury, any type of inhibition associated with that. And so paying attention to the quality of the contraction through the range of motion is important to me.
And that's going to be picked up a lot next month as well. Again, today we're talking isometrics as a way to track those early strength gains. But John, you test your total knee patients eccentrically, isokinetically. Is that safe?
It is safe because again, we do a warm up, we do a training program. They don't just walk in and load at a very, very high level of strength. And again, it's not a fast speed test. It's not an aggressive test for them. It's one that we're able to see whether or not they have functional motor control, both concentrically and eccentrically for function.
Absolutely. And you can go back
and that's
to
the big reason that we want to test.
Yeah, and you can go back to different training modules or episodes that we've done because you don't just have your total knee patient walk in day one and test them. You run them all through those various stages of the rehab and you test them later on when it's appropriate.
And how many of our total knee patients, or really our older adults, when we start to question where they have functional problems, they don't have problems going upstairs.
No.
They always have problems going downstairs. So we ought to be looking at what their functional deficits and how we're testing and training to overcome those deficits.
Absolutely. And I wanted to, I try to include a lot of the questions that we get as part of the presentation. So I wanted to give a little preview into how deep you're going to go into that next month as well. And John could probably talk for 3 hours on that, but we have to limit him to 1.
Yeah, that is very true. I'm trying to put it together so that I can actually get through it in an hour, quite honestly, because there's so much information that you may want to get into. But that would be the advantage of the users meeting in the future. It gives us opportunities to have a one-on-one conversation, over a beer or pizza or something at the end of the day and talk about some of these studies. And it's interesting because, we don't want to just cherry pick studies. That's never a really good thing to do. We want to look at studies that, have good fundamental basis behind them, that are done by good researchers. If you look at a lot of studies that you saw, the name that keeps coming out for me over and over and again is Hewitt. Hewitt's a great biomechanics specialist at the Mayo Clinic, and he has some fantastic work on ACLs. Lynn Snyder-Mackel at Delaware has produced some fantastic work. So we need good researchers that understand this topic, that are producing that type of information for us in the future.
Absolutely. All right, John, that wraps it up.
Daniel, great job. We appreciate it. Rob, you got anything else to say at the very end here?
Nope, other than Daniel and John, great job. Daniel, the studies were great. I think the oldest study was from 2014. It's always nice to see new researchers supporting what we say. So well done.
All right. Well,
and again, one more time before we go. Yep. If you guys are interested in that users meeting, let Rob know that that's something that you guys want to get into. All right. Have a good night. See you. Bye.
Cheers.